Hello everyone. Let's start the second segment of this second lecture on the abdominal viscera. So in this one, this will be the last segment of this lecture, and in this segment I will be talking about the formation of portal vein, the portocaval anastomosis, the pancreas, spleen, and the blood supply of these organs. Okay, so let's get started with the formation of portal vein. Portal vein is formed by the union of splenic vein with the superior mesenteric vein, and inferior mesenteric vein is a tributary to the splenic vein. So the blood from the inferior mesenteric vein, they join the splenic vein, and the splenic vein eventually join the superior mesenteric vein to form the portal vein behind the neck of the pancreas. Okay, and then it travels towards the liver. Now, portal vein drain all the stomach, the spleen, the luminal GI tract, the whole GI tract, and also the gallbladder. These all areas are drained by the portal vein, and then the blood in the portal vein that travel through the liver eventually drain into the inferior vena cava. Okay, so now the important thing is that the end product of digestion, so the digestion and absorption takes place in the small intestine, right? So all the end product of digestion, the food that we eat after digestion, they are absorbed into the blood, except for a few exceptions of like some long chain fatty acids. So all the end product of digestion are absorbed by the portal vein, and they are carried through the liver, eventually drained into the portal vein. Into the inferior vena cava. So that is the formation of the portal vein. And normally, under normal circumstances, 100% of the portal blood can be recovered from the hepatic vein, which means the blood that is carried by portal vein, 100% of it travel through the liver and collected by the hepatic vein, eventually hepatic vein drain in the inferior vena cava. So, but there are in our body, in the certain areas, there are anastomotic network between the tributaries to the portal vein and tributaries to the systemic vein. So when we say systemic vein, eventually all the blood goes to the systemic vein, but the portal vein, initially they drain into the portal vein, into the tributaries of the portal vein, they travel through the liver, and then eventually they drain into the vena cava. But these are the portal vein. Now the systemic vein are the ones that they are not the part of portal venous system. They drain directly into the systemic vein. So those we call systemic vein versus the portal vein. Okay, so in our body, in certain areas, there are communication between the tributaries of the portal vein and the tributaries of the systemic vein. So I will mention three such areas. One around here in the lower part of the esophagus. As you can see, this is the end of the esophagus. This is the beginning of stomach. At the end of the esophagus, there is a anastomotic network between the portal venous tributary, which is coming from the left gastric vein, the esophageal vein, and the esophageal vein that drains directly into the azygos vein. So this is a portal vein, systemic vein, and this is a portal vein, the anastomose around the lower part of the esophagus. Another such very important area is around the rectum, where you see the suprarectal vein, which is a tributary to the inferior mesenteric vein, which means it is a tributary to the portal venous system. They anastomose with the middle and inferior rectal vein, which drain into the the common iliac vein, through the internal iliac vein to the common iliac vein, which means they are the systemic veins. So which means around the rectum is another area where you have anastomotic network between the tributaries of a portal vein and tributaries of a systemic vein. Another such area is around the umbilicus, where the epigastric veins, which are tributary to the systemic vein, they anastomose with the paraumbilical vein, which are the tributaries to the portal vein. So these are the areas of the significant areas of portocaval anastomosis. Okay, but as I mentioned, normally 100% of the portal blood travel through the liver and through the hepatic vein goes into the portal vein, which means not much blood is flowing through these anastomotic channels, right? But under certain circumstances, say like a classic example is the cirrhosis of the liver. When that happens, liver parenchyma, normal liver parenchyma is replaced with fibrous tissue. Now, when liver parenchyma loses its normal architecture and it is replaced with fibrous tissue, then what happens is that as the blood flows through the liver parenchyma, they offer much higher resistance to the blood flow. At some point, they don't let any blood to flow through the liver parenchyma. Now, when this happens, the pressure in the portal system goes up. That is a situation we call portal hypertension, which means pressure in the portal circulation is high. Why? Because the portal blood cannot travel through the liver parenchyma to be drained into the hepatic vein. Okay, so if that happens, the blood in the portal circulation will try to find some alternate routes to return to the systemic circulation, right? So these are the anastomotic channels will now be a new route for the portal blood to be transmitted or transferred to the systemic circulation, right? So as more than normal blood start flowing through these anastomotic vessels, these vessels become enlarged because they are now transmitting lot more blood than they normally do. As a result, the vessels, the veins in this area of this particular area will be dilated, giving rise to varicose vein. Now, these varicose vein have different name in different areas. When it happens around the esophagus, we call them esophageal varices. Now, esophageal varices, if this situation if left untreated, the veins in the esophageal varices, the participating vein in this anastomotic network may get busted actually, and then that may cause serious hemorrhage and serious bleeding that can be even fatal. The bleeding from the esophageal varices. The same thing can happen around the rectum as well, because more blood will be flowing through these vessels, through these veins. As a result, these veins will be dilated around here and giving rise to the varicose vein around the rectum. And around the rectum, when it happens around the rectum, they are called the hemorrhoids. Okay. And then the third important area is around the umbilicus. When the vein around the umbilicus are dilated, they give rise to a typical shape of caput medusa, and they are called caput medusa. That happen as a result of increased portal blood pressure, and as a result, the veins in the portocaval anastomotic side are enlarged. Okay. To remember these three areas, we use this mnemonic-like thing. We say the gut around the esophagus, the butt around the rectum, and the caput because of its shape of the caput medusa around the umbilicus. Okay, so now if this thing happen, as I said, we cannot keep these things untreated because these varicose vein around these areas may get busted and then cause serious hemorrhage, which can be life-threatening. So to alleviate this situation, one procedure that is commonly used is called transjugular intrahepatic portosystemic shunt. So in this process, what is done is that to bypass the liver, because the liver is creating problem because it is giving more pressure, more resistance to blood flow. So to avoid the resistance offered by the abnormal liver parenchyma, a bypass is made. The liver is shunted actually by connecting the portal vein to the hepatic vein in the liver, so that's how you bypass the liver, so the blood in the portal vein can still go into the hepatic vein. But one problem of that is that we don't want blood to bypass the liver, because the blood, as the blood flow through the liver, it serves a very important purpose. So as we absorb the end product of digestion from the GI tract, some toxins also are absorbed, and they travel also in the portal vein. Now, as the blood flow through the liver sinusoids, I will show you a histologic slides of liver sinusoids. The mixed blood from the portal vein and the hepatic artery, they are mixed in the hepatic sinusoids, and as the hepatic sinusoids travel through the liver parenchyma, the hepatocytes, they pick up those toxins and they detoxify them, so that those toxins cannot reach the systemic circulation. Because if that is not done, if you bypass the liver, what will happen? All these toxins will bypass the liver and they will get into the systemic circulation, and if they can reach brain, that they can cause damage to the brain tissue. So this is very important, that the portal blood, 100% of the portal blood travel through the liver parenchyma, and then after that they drained into the infravena cava. Now let's talk about the pancreas. This is an isolated the pancreas without any surrounding structures, and you can see the part of the pancreas include a head, a neck, a body, and a tail. Okay, and also an extension from the head is called the uncinate process of the pancreas. Pancreas is a gland, and it's a mixed gland, which means it contains both the exocrine part, this is the exocrine pancreatic acini, which are the part of exocrine pancreas, which secrete digestive enzymes into the duodenum, and also the endocrine part of the pancreas, which is about 1% of the pancreas, that is called the islets of Langerhans. Islets of Langerhans is also absolutely important because this is the endocrine part of the pancreas, and they secrete very important hormone like insulin, glucagon, somatostatin, like that. So that is the function of endocrine pancreas. Now here we can see the pancreas with the surrounding tissue. See, to visualize the pancreas, we have to cut the stomach here, which means if you leave the stomach in place, you cannot see the pancreas. Pancreas lies posterior to the stomach. That is the relation of pancreas to the stomach. And its head lies around the C-shaped curvature of the duodenum, and its tail goes all the way to the hilum of the spleen. Okay, so that is the relation. And look at the uncinate process that lies posterior to the superior mesenteric vessels, and the neck of the pancreas lies anterior to the superior mesenteric vessels, because you cannot see the superior mesenteric vessels because the neck of the gallbladder lies over them. Okay, so that is the relation of pancreas with the superior mesenteric vessels. Now this one shows the duct system of the pancreas. As I said, pancreas secrete very important digestive enzymes and also bicarbonate, which is absolutely important for the conversion of this the environment here into an alkaline environment, which is normally acidic because of the acid chyme that enters the duodenum from the stomach. So now you see, this is the pancreatic duct carrying the secretion from the pancreatic acini throughout the whole pancreas, and around the head it joined the bile duct to form the hepatopancreatic ampulla, and those joint duct of the bile duct and the pancreatic duct forming hepatopancreatic ampulla open in the second part of the duodenum, which is marked by the major duodenal papilla. Okay, so that's, I think, all about pancreas. Now let's talk about the spleen. Spleen is an organ of reticuloendothelial system, and it has two surfaces, one relatively smooth diaphragmatic surface and the visceral surface. Now whole spleen, the diaphragmatic surface, is covered by the pancreas, which means it is an intraperitoneal structure. On the visceral surface, it is also covered by peritoneum, except for the hilum, where the splenic artery enters the spleen and splenic vein leave the spleen. Okay, and the location wise, spleen lies in the upper left quadrant in the 9 division. If you divide the abdomen into 9 division, it will be located in the left hypochondrium. Okay, the adult weight is about 160 gram. One of the important function of the spleen is, as the blood travels through the small splenic vessels, the aged or old red blood cells, they cannot squeeze through those small vessels, and they are broken down, and that's how the old aged red blood cells are removed from the circulation by the spleen. Okay, now look at this position of the spleen. This, in the anterior view, you can see spleen is protected by the 9th and 10th rib. It can extend all the way to the 11th rib as well sometime. So in the anterior view, so they are under the rib, under the diaphragm as well. And because of that, as they are protected by the rib, the spleen cannot be palpated in the anterior or lateral abdominal wall. Only when the spleen is enlarged, they enlarge in this direction, and at that time spleen can be palpated. Okay, look at the spleen protected by the 9th and 10th rib mainly. So now, because spleen is covered by a thin capsule, any injury on this area of the anterolateral abdominal wall on the left side around the 9th and 10th rib, or a fracture of 9th and 10th rib, can causes the rupture of the spleen. And as spleen is a highly vascular organ, it can cause serious bleeding. Okay, and another problem that is not very uncommon in spleen is the splenic enlargement. Because spleen is an organ of reticuloendothelial system, so any disease that involves the reticuloendothelial system, like leukemia or lymphoma, that can cause the enlargement of the spleen. And if the spleen is enlarged at that time, at that situation, it can be palpated and below the costal margin. Now, this is a transverse section of the abdomen around at the T12 level. This will give us some idea about the spleen and its surrounding structures. As I said, spleen lies behind the stomach in the left hypochondrium or upper left quadrant. So, and then you can see the peritoneal reflection also, the peritoneal double fold of peritoneum. As I mentioned before, when the double layer of peritoneum connect the two organs, we call them the peritoneal ligaments. One such ligament connects the stomach to the spleen, we call gastrosplenic ligament, which contain the short gastric vessels, which are the branch of the splenic artery. And also another ligament, which is the splenorenal ligament, which is a ligament, again the peritoneal fold between the spleen and the left kidney, we call splenorenal ligament, which contain very important vessel. The splenorenal ligament contain the splenic vessels, both splenic artery and splenic vein. Now, related to this, you can see the ribs protecting the spleen, and this is the diaphragm here. And also you can see some other important peritoneal structure here. You can see the peritoneum connecting the visceral surface of the liver to the stomach, which is the lesser omentum. And lesser omentum has two portions, as I mentioned before. The part that is between liver and the stomach is called the hepatogastric ligament, and part between the liver and the first part of the duodenum is hepatoduodenal ligament. Another important thing you can see here is the omental foramen. We call epiploic foramen, which is the communication between the greater peritoneal sac and lesser peritoneal sac. Lesser sac is around here, right? Now, this is the communication between the greater sac and lesser sac. And as I mentioned before, the anteriorly and posteriorly, there are very important structures anterior to the omental foramen and posterior to the omental foramen. Anteriorly, again, this is the portal vein, a hepatic artery, and bile duct. And posteriorly, it's the inferior vena cava. For any reason, if you have to approach the lesser sac through the omental foramen, you have to be extremely careful about the structures which are located anteriorly and the structures located in the posterior direction as well. And you can see the attachment of anterior abdominal wall with the liver forming the falciform ligament here. Okay, now let's talk about the blood supply of these organs. So again, our organ of interest in this lecture include the liver, the gallbladder, pancreas, and spleen. Now, the spleen gets its blood supply from the largest branch of the celiac trunk. You see the aorta is entering, this is the diaphragm, right? So aorta is entering through the diaphragm through the aortic hiatus, and immediately it gives a branch which is celiac trunk. Celiac trunk, the largest branch of the celiac trunk is splenic artery, which is large and also tortuous, and it provides blood supply to the spleen. And liver's blood supply comes from hepatic artery. Hepatic artery originates from the celiac trunk as a common hepatic artery, and then after giving away the gastroduodenal artery, it becomes the hepatic artery proper. Now, hepatic artery proper divides into right hepatic artery and left hepatic artery, which provides arterial blood supply to the liver. Okay, and a small branch from the normally come from the right hepatic artery. It may come from left hepatic artery or hepatic artery proper as well, called the cystic artery, that provide blood supply to the gallbladder. Okay, now the pancreas is supplied, and pancreas and the part of the duodenum, they receive blood supply from both vessels, the celiac trunk and superior mesenteric artery. Okay, we mentioned before that celiac trunk provide blood supply to the derivatives of foregut, and the superior mesenteric artery provide blood supply to the derivatives of the midgut. So now the pancreas and duodenum, they are in the junction between the foregut and midgut. And so foregut ends here at the opening of the major duodenal papilla. Okay, at the opening of the hepatopancreatic ampulla marked by major duodenal papilla. So lower part is the derivatives of the midgut. And so the duodenum and pancreas, they receive their blood supply from both celiac trunk and superior mesenteric artery. The blood vessel include the branch of celiac trunk, the splenic artery, that are the dorsal pancreatic artery and great pancreatic artery. These are the branches coming from the splenic artery that provide blood supply to the pancreas. And also the superior and inferior pancreaticoduodenal artery. Superior pancreaticoduodenal artery is a branch of gastroduodenal artery, which is eventually a branch of celiac trunk, and inferior pancreaticoduodenal artery is a branch of superior mesenteric artery. And both inferior pancreaticoduodenal and superior pancreaticoduodenal, they divide into anterior and posterior branches, and both branches eventually anastomose with each other. Okay, so that is the blood supply of these organs, and I think that's all I have for you in this lecture. And as I said about this lecture or any content in the module, if you have any question, don't hesitate to let me know. You can contact me by email. You can send me text message. I sent you my cell phone number. You can call me, whichever is convenient for you. So thank you for your attention. As I said, anytime, any need, you can call me, text me, or email me. Thank you for your attention.